So perhaps we can now go on to hear from Ruth Rankine, who has had a very wide range of experience in the National Health Service. She's been a junior parliamentary secretary to the chief executive of the NHS and permanent secretary, which is a sort of window at the very top. She's worked in the NHS Confederation, where she was involved with the GP contract, which we all think about so much. And she's been a strategic director for NHS Direct, which is another major development in the NHS. Now she's the Deputy Chief Inspector for the Care Quality Commission, known as CQC. And this is the inspectorate in the NHS, not just for general practice, but for hospitals and social care as well. So here is somebody at the very centre of the inspection process, and we very much look forward to hearing from you.
Okay, good morning everybody. Thank you for inviting me to come to your conference on a lovely Saturday morning. I have to just say it's been a bit eventful actually getting here because I thought it would take about an hour and a half. I live in Kent and I've seen Patricia a few times this week, and every time I saw her she added to the list of things that might disrupt my journey. So we started with the M25, which, as you all know, is a problem. And then when I saw her, she said, "Ruth, I just need to let you know there's roadworks on the M3 and M4. Okay, fine, right, we'll add 30 minutes on for that. Next time I saw her, she said, "And don't forget about Ascot." Okay, right, that's another half an hour. And then Edith and Sandy got involved as well. And we added on Glastonbury and everything else. So as a result, I left at 6 o'clock this morning and I was here at 7. So that's why I'm wearing my glasses. And my husband kindly chauffeured me here, so he's watching the rugby. Right, so as you know from my biography, I am Deputy Chief Inspector of CQC. I have a regional responsibility for the south of England, and looking at the list, I know many of the PPGs here today are from practices in the south of England, so if you want to form an orderly queue during the break, I will be happy to discuss your practice in detail. Today I want to talk to you about three things. One is just to remind you of the role of the CQC if you're not familiar with it. Two is to summarise what we have found from our first round of GP inspections. And the third thing is to talk about your role. The role of the PPG, both now and going forward into our new strategy. Now, I do have a lot of slides and they will be available, so I won't necessarily go through them all in detail, and we'll have time for conversation. So, just to remind you, the CQC is a regulator of health and social care. It is independent, and we see our role as acting on the side of the people who use services, patients and the public, and therefore understanding people's experience of the care they receive is absolutely fundamental to what we do. We regulate as per the Health and Social Care Act. So if you are a provider of regulated activities, which is a long list of things in the Health and Social Care Act, you must register with the CQC. We have over 50,000 providers registered with the CQC, covering primary care, secondary care, and social care, and also we regulate the private sector. So if the private sector is providing regulated activities, even if they are not paid for by the NHS, if you pay for them out of your own pocket, they must register with the CQC and we will regulate them. So since 2014, we have been using this approach to regulate services. So there's four key components. I've talked about registration. And once a provider is registered, then we have a process of ongoing monitoring of that provider using the intelligence and information that CQC receives, which can come in a number of forms. So there is obviously nationally published information on a number of providers. For general practice, that might be quality and outcomes framework. But equally, on our website, we have a form which is called Share Your Experience. So that's where members of the public or healthcare professionals can anonymously or with their name provide information about their concerns of a provider that they may be aware of or may be using. As well as monitoring, we will inspect the providers, and most providers we inspect, we also give a rating to as well. Where we find problems or we see evidence that patients may be at risk or have been at risk, then we will take enforcement action. Now that action can range from just what's called a requirement notice. So that requires the provider to do something, and that may be to produce an action plan to say how they're going to address the issues that we have found. But at the most extreme end, we can go to a magistrate's court very quickly and seek their agreement to close a practice urgently. And we have done that in general practice in extreme circumstances. And the final element of what we do is we publish the reports of what we find, both in terms of what we find on inspection, but also we are increasingly at a national level publishing reports about the state of hospitals or the state of social care. And within the next few weeks, we will be publishing our report on the state of general practice based on what we found over the last 3 years. So I said that central to our approach was understanding the patient and public experience, and we do this in a number of ways. So we talk to the public as part of an inspection. We use experts by experience on our inspection. So these are people who have signed up to work with CQC, who are users of services. And they will often join us in inspection, and they take the role of talking to public and patients on inspection. We will talk to local groups. We also look at the results from national patient surveys. And as I said earlier, we look at the range of information that we've received throughout the year, in terms whether that be from complaints or other information that we receive in CQC. A lot of the information we receive as well, you should be aware, is from whistleblowers. And those whistleblowers are often members of staff working in that provider, and they are identifying that there is an issue and it is serious enough for them to anonymously let us know. So just to recap on our ratings, I'm sure you're all familiar with these. We have 4 ratings: outstanding, good, requires improvement, and inadequate. For those practices that are in the requires improvement and inadequate category, some form of action may be taken to protect patients. And as I've said, in the worst cases, we can close or suspend practices where we have evidence that patients may be at risk. One of the things that I would ask you to take away as an action is it is a requirement on general practice to display their ratings in their practice in a place that people can see. After they have received their report and their rating, they are given access to the resources where they can print off the table which shows the ratings against each of the areas that we look at, and also for each of the population groups that we look at within the practice. I had to remind my own practice the other day as I sat in the waiting room and couldn't see it anywhere. You can imagine they just hate me coming through the door. So I'd ask you to take that away as an action. So we've now completed our first programme of general practice inspections. We've inspected around 7,500 general practices across the country. And the overwhelming picture, reassuringly, is that the majority of general practice is good. However, 1 in 10 practices needs to improve. And over the time that we have been inspecting, so if a practice is inadequate, we will go back and re-inspect it in 6 months. If it requires improvement, depending on the timescale for fixing some of the issues, they will receive an inspection, but we will do a full re-inspection within 12 months. And what this diagram shows you is the improvement that we have seen from the first time we inspected the practices to the second time we inspected the practices. Sadly, though, we have also seen practices get worse. So we are seeing an increasing number of practices that were rated requires improvement, and we've had some intelligence, information, which suggests we need to go back and look at things. And when we've gone back, we have now rated them inadequate. And in some cases, practices have been rated inadequate and put into special measures, which is sort of gives them access to a support program of support. We have re-inspected and rated them good. And you think that's great, well done. And so, we think that's fine, we can leave them alone for a bit. And in one case, we got 10 pieces of information from different whistleblowers, both within the system and within the practice. So we went back in within this was about 6 months after the practice had been rated good, maybe 8 months. And what we found was catastrophic. And we urgently suspended the practice. So the question is, what happens in that situation where within a period of 12 to 18 months, a practice can go from inadequate to good and back to an urgent suspension? And in fact, in that case, what we found was the commissioners had taken their eye off the ball. The contract for the practice had been given to a new provider. There was no local leadership. Most of the staff were locums. Staff were leaving in droves. And one of the locum GPs said to us, I know that patients are at harm as a result of what we're doing. So it's one of the things that we will be looking at going forward is what's happening in those situations, and is there something about the support that isn't there for the practice within the system to prevent that from happening. So you know that we look at 5 key areas of when we go in and do an inspection. And where we find most concern is around the safety of the practice and also how well run it is. So we often see basic safety issues not being dealt with. So you will know that CQC gets criticised for looking at the temperature of fridges. And you know that we get criticised possibly for looking at the minutiae, and such as out-of-date medicines. And is there anything really wrong with keeping your sandwiches in the vaccination fridge? But what it can highlight is a fundamental problem with how the practice is run day to day. So in isolation, they may not be significant, but the more you look into it and the more of these isolated issues you find, you will find a problem with the leadership and oversight and governance of the practice. So what makes a practice outstanding? Well, key to this, as I've said, is leadership. I would say it is the number one factor, both in terms of the clinical leadership and non-clinical leadership. Ensuring that the practice is safe, ensuring that they understand the needs of their patients, and that they are responding to those needs, both in terms of the access that's provided and the services that are provided. That they are working with others to continually learn when things go wrong, and to share that learning, both within the practice but also outside the practice. And they are also proactive in continuously improving care and services for patients. And of course, they always have a very good PPG as well. Conversely, a practice that is rated inadequate will often be quite chaotic and disorganized. If things go wrong, or when things go wrong, they don't learn from it. They don't understand that they need to understand why it went wrong and what they need to do to avoid it in the future. There's a lack of teamwork, and often the staff in the practice are undertaking roles that they're neither trained for, nor in some cases qualified to undertake. They have really no understanding of what their patients need. And very often there's no PPG. So we've seen some really inspiring examples of what practices are doing. But equally, we've seen some that really make the hairs on the back of your neck stand up when you see it. So the top left quote is, so this is from an inspection report of a practice in the south. And in this case, we found a, in quotes, doctor seeing patients. So the partner GP was off sick, and when we talked to this doctor and talked to the staff in the practice, actually we found out that he wasn't a doctor. He was seeing patients as if he were a doctor and a GP, but he was an osteopath. He recognised he had no qualifications or training to see people, to take tests, to make referrals, to prescribe. And this practice was urgently suspended and closed within 6 months, with 10,000 patients on the list. The bottom right-hand example is, it wasn't just one prescription that hadn't been processed, nearly 700 requests for repeat prescriptions, a significant number of which were for people with asthma, so needing asthma inhalers. And when they rang up to check if their prescription was ready, they were told to make an appointment with the GP. And when they tried to make an appointment with the GP, they were told they'd have to wait 3 weeks. So the quotes don't necessarily give you the detail of how bad some of the things we find are. But hopefully you will understand why we have to sometimes take the action we take. And in the bottom right-hand corner, that was an urgent suspension. There were lots of other issues, but that was just one of them. So why are PPGs important? Well, in a nutshell, we need you to help us understand what's going on. We need you to be brave enough to tell us when something isn't right, at the risk of the consequences. because what we found is that a proactive PPG that's open, honest and objective is a sign of a very good practice. We already involve PPGs as part of our approach, both before, during and after inspection. So what's important to us is we want to know what you think. We want to know about your relationship with the practice. We want to know what's working well. And we want to know what you have suggested to the practice needs improving. And where it has improved, we want you to tell us what impact it's having, what difference is it making to the care that patients are receiving. So we find lots of examples of PPGs working constructively with the practice. When I was preparing for this presentation, I sent a note to our inspection teams across the whole of England. So we have 40 inspection teams that cover the whole of England, saying, could you please send me examples of where you've seen it work really well and where you've seen it not work so well. And I was absolutely inundated. I got hundreds of examples of really, really positive work, really innovative approaches in terms of how the practice and the PPG are working together. But very often we find that the PPG isn't fulfilling the role of being an objective, critical friend. So often the views are quite one-sided in terms of the groups of patients that they're representing, and more commonly, their views are not in line with what the GP patient survey is telling us. So these are some quotes from some of the positive reports that we've had, but also where things aren't working so well in terms of the relationship between the practice and the PPG. But more significantly and more worryingly is when we receive positive feedback from the PPG, but everything else we find in the practice is putting people at risk. So I've seen PPGs that are worried about saying something negative because they're worried about the impact that will have in terms of the practice and the action that we might take, and that will make it worse for patients. But I would ask you to consider the impact of practices not delivering the care patients need when they need it, in the way they need it. So what do I ask of you? Well, I ask that you act objectively, both in terms of the views you represent and in terms of how you see the practice. I ask that you embrace the role that you've been given, that you hold the practice to account for the care that they deliver to those you represent. And I go back to my earlier point, is where you find a fully engaged, representative, open and honest PPG, you will find a good or even outstanding practice. And I know that on your agenda later on, you've got a session with the RCGP around what PPGs can do to support practices that need to improve or are in special measures. I think you've got a really, really important role in helping them and in demonstrating to us that you have been working with them to help them address the issues that they need to address. So moving forward, the CQC's strategy after completing thousands of inspections is actually to shift the balance. That's not to say we're not still a regulator, but actually we have a responsibility to encourage improvement. And we will move towards more monitoring and less inspection for those that are good or outstanding. For those where we still have concerns, they will receive the same oversight as we have been doing currently. We will work with our partners in the system, so CCGs, so that we have a common view of quality, because too often the CCG will tell us everything is fine, and when we go in, we find things aren't fine. Or we will go into a practice having had no information from the CCG and find real concerns, which the CCG was aware of, the LMC was aware of, but they didn't tell us. And what's worrying is that at the end of our program, we were finding as many inadequate practices as we were at the start of our program. And people in the system knew, and they didn't share the information with us. So, and as an organisation, we are committed to improving our efficiency and our effectiveness and continuously improving. So looking ahead, I said at the start that we'd learned a lot over the last 3 years, which is influencing how we move forward. So if 90% of general practice is good, we will move to a more proportionate approach in terms of inspection. But monitoring therefore becomes even more important. And we are sitting on a wealth of information, so 7,500 reports of what is happening in general practice. We have a responsibility to share that information so others can learn, and that we can continue to champion general practice for the vital role that it plays in the system. So going forward, we want to focus on outcomes. Yes, fridge temperatures and medicines in date are important, but actually we're shifting the balance towards what is the practice doing that's improving outcomes for patients. So actually PPGs do have a really important role to help the practice assess the impact of what they're doing. We see lots of practices doing really exciting, innovative projects. And when we ask them, so what difference is it making to patients, they can't tell us. So what we're looking for is practice that is doing exciting things, but actually they know how to measure the impact, and that if it's not having the benefit that they intended, they stop and they try something else. And that's where the PPG comes in, because you can help them and you can tell us what difference it's making to the lives of those people you represent. So I'd leave you with 3 questions. How do we at CQC ensure that we hear the voice of the patient in what we do? How can CQC support PPGs in what we need you to do? And finally, what are you going to do differently as a result of the discussion today? Thank you.
Thank you very much indeed. That was equally challenging and really a very strong start to this conference. Could I ask Professor Rankine to join us on the platform, please? Both the speakers have run beautifully to time, so we now have 20 minutes for you and questions. When you ask questions, could you please give your name and the area from which you come? First question.
Please wait for a roaming mic, please.
Oh, right, okay. Where, is it coming, is it?
Yep, just grab it with you.
Right, okay. Thank you very much, that was fine. Okay, right, so right in front of you, Paul.
My question is directed to...
Could you give your
Professor...
name and
sorry.
background, please?
Yeah, sorry, my name's David Ashton. I'm a PPG chair in Crouch, which people won't know about, but it's a practice in Derbyshire, in the Derbyshire Dales. Thanks for an excellent presentation. It resonated as chair of a PPG, which I think is a good practice that we're linked to. But I was wondering, in a sense, you talk of a paradigm shift, and I can see exactly what you're saying and where we're going, but there doesn't seem to be any reaction from the government in terms of instigating a new, if you like, a new paradigm, a new relationship. The only game in town seems to be STPs, And our experience of that, or my experience of that, has been very depressing. But I was wondering I really wanted to know what your view is, and what direction can we change take place, and how can that be, in a sense, introduced? And are STPs the kind of, if I like, the way forward? Thank you.
Paddy?
I think your comment is a very prescient one, and it's well evidenced by my experience in the last year.
Sorry?
What's an STP?
It's a sustainability
Is this microphone
transformation.
live? Is this microphone live? Okay.
An SDP is a sustainability transformation plan. It was a Department of Health NHS plan to initiate changes and reconfigurations within the NHS to make things more efficient or expedient or suitable to local functioning. Yeah. I think your comment is really a very prescient one. And in the last year, I've had meetings unofficially with people from the Department of Health and from the NHS. And I can confirm that there has been no move to set up any kind of think tank to think about the future. At the moment, our government and our various departments are concerned very much more with firefighting, with all the problems that exist on a day-to-day basis. And this is worrying because even people who are thinking about roads and cars and so on are trying to draw up plans for what the country might look like in 10 or 15 years. But there's nothing happening in terms of health apart from isolated thoughts here and there. So, in fact, as a result of this BMA exercise, what I'm endeavoring to do is to set up initially a UK-based think tank to bring to people's attention what's happening and combine that with an international think tank. So we've taken the first few steps in trying to get the partnerships going with the GMC, with the Royal Colleges, but also with big organizations like Google, who have a huge role to play in the future of health. But you're spot on. There isn't any thinking going on.
So, can the microphone be got to this side of the room, please?
My name is Mike Bright, and I'm from the Dolphins practice in Haywards Heath. And you have raised the question of different values and expectations and a shift in the role of GPs and related to expectations. Would you agree that it is the responsibility of NAPP and other related networks associated with the health service to highlight to the government that the idea of the costs of prescriptions and procedures and services are known to all patients, because the lack of this information is driving higher and higher expectations from the patients without sufficient patient responsibility, including the access to GPs, which is overwhelming at the moment, and we are all trying to devise ways in which we can triage prior to a doctor's appointment, but the expectations become higher and higher.
I think that's an extremely good point, and one that was raised at our international conference, that in the spirit of openness, just as patients are, or members of the public are well aware of what their medical condition might entail, because they can look it up, they can read about it. So similarly, the whole issue of costs ought to be made more transparent. I think it's an ongoing debate, because some people might be put off, in theory, seeking a treatment which they think is terribly expensive, and they have the sort of old-fashioned stoical mustn't grumble approach amongst themselves. But I'm certainly of the view that greater transparency in costs should be enabled. And on the back of your question, I would encourage patient participation groups and you as an individual, to open a dialogue with your MP and also with the Department of Health and so on, to inform them of your wishes and views. They do take note of what comes through at governmental level. And I think that's where the power bit comes in. That's the bit about looking beyond your own practice.
We've had 2 questions for Professor Hungin, and we've got 2 distinguished speakers on the panel. So could I have a question, please, for Ruth Rankine?
Chris Wardley, a patient representative from Oxfordshire. Yes, my question is for Ruth. Oxfordshire CCG are asking patient groups, in what way do they think patient groups acting as critical friends can make use of the quality outcomes framework or other such information to encourage practices to make improvements in quality of service. That obviously raises a side issue with the doctor. Would such an approach be seen in the current climate as helpful or unhelpful?
Well, I go back to what I said earlier about holding practices to account. There is publicly available information on NHS Choices which sets out a range of indicators for every practice, and it includes the CQC ratings, it includes a number of measures from the Quality and Outcomes Framework, and that information is freely available. And for me, when I talk about challenging the practice and holding them to account, it's not in a destructive way, but the PPG working in partnership with the practice to improve patient care, and it's the practice understanding how the PPG can actually help them. And is there something actually that, going back to previous comment, is there something about patient understanding of the issues and the challenges that the practice is facing, so that expectations can also be managed, because we know the challenges that exist in general practice, and there's not an endless pot of money, so some difficult choices have to be made. But certainly, outcomes is one of the things that we pay close interest to.
Beside you, on your right.
All right, sorry.
Good morning. My name's Brian Shern of Cookham PPG, Berkshire. My question really is, assuming that you are responsible for the friends and family tests, do you still perceive there's a value in those? Certainly my personal perception is this is something which has to be done by surgery. People don't know they're supposed to do it every time they see the doctor. It's something which has to be done. That question has been asked now for, 2 years or more. Would it not be better to get a questionnaire which, for instance, you're saying where a practice has an initiative to find out what the result of that is, to say, fine, okay, have a specific questionnaire for that initiative?
So we're not responsible for the friends and family test. The survey results that we look at is the National GP Patient Survey, which is obviously a Department of Health initiative, and that's the official results that we look at. We do look at the friends and family test in the same way we look at comments on NHS Choices, but they don't carry a lot of weight in terms of the judgments that we're making. The issue with the GP patient survey, of course, is it's quite a small sample of patients, and again, looking at really good and outstanding practices, they will be very proactive in encouraging their patients to complete it. but quite often in practices we see that it only represents about 1% of their practice population. So again, a really forward-thinking practice is doing their own survey for exactly the reasons you're suggesting, and that's often the PPGs are designing those surveys and running that on behalf of the practice. So actually, you know, where we look at, because the practice has recognised that the national patient survey is limited, and they want to really, you know, there's specific things they want to ask or they want to find out, they want to get beneath something. So, you know, we see that as a really positive move where they're doing their own surveys, or they're delivering a new service, or they're delivering things in a slightly different way, and they will do surveys throughout the process so that they can demonstrate the improvement over time.
Dennis, may I respond in an unsolicited manner to something that's quite important, I think. Ruth, I felt that our presentations fitted in really well, but they came this morning from opposite ends of the room. I'm saying GPs no longer want to be partners. They want to be locums. They don't want to work in a practice for life. They want a portfolio career. They only want to work 1 or 2 days a week quite often and then have a break. And the level of organization and management required in a practice is the sort of stuff that GPs many younger ones are not wanting to be interested in. You are evaluating things from a viewpoint which would certainly have been, by the way, my practice was judged outstanding.
Of course. You can pay me later. But your judgment in a way, and I have no disagreement with you, is based not on the current factorial design of society and of general practice, but on a model that would have been ideal 10 years ago. And I think there's a basic tension. That practice you described as only one locum who said, I fear for the harm of my patients. Well, I mean, who are you inspecting? There isn't a practice there.
At the back. At the back.
Thank you. Mike Baker. I'm from a PPG in North London near Golders Green. Ruth, you used the words hold to account and critical friend. I'm pretty sure, almost certain, those words or things like that don't appear in the draft terms of reference that the NAPP supplies to new groups. I personally think they should, and I also think it would be, if you had some input to that, it would be fantastic if the BMA's GP committee approved that as well, because I have a suspicion that there would be a number of GP practices who really wouldn't welcome their PPG having the role of critical and challenging friend.
I think it's a really good point, and in preparing for today, I had a look at the terms of reference that I think NHS England put out, and I was surprised to see that those sort of words weren't in there. So it sounded a bit, forgive me for saying this, cosy. So I knew I would be challenging in using those words, and I thought people may challenge me. So one of the discussions that we have been having with Patricia is producing some joint guidance. So there's lots of resources on our website, if you can find them, I have to add, and there's something called Nigel's Surgery. So Nigel is our senior national GP advisor, Professor Sparrow, you may know him. And it really started from when we started inspecting, there were lots of myths around, you know, it was like Chinese whispers. And one thing escalated, and you know, when you heard it, you thought, where on earth has that come from? So we started producing Mythbusters. which basically say, no, look, this is what we're talking about, so this is the definitive position. So one of the things we've been talking to Patricia about is producing a sort of a myth buster around, you know, what do we see as the role of PPGs and how can PPGs help the practice and help CQC and ensure that we're all working to a common purpose in ensuring that the practice is achieving the best outcomes it can for patients. So, you know, absolutely support that, and that's something we'll be doing over the next few months.
Time is beginning to press, so we must be careful. In the middle there, please, yeah.
This is a question for Ruth, and I'm Pierre Landell-Mills from Dartmouth, chair of the PPG. It's really great to hear you saying you support the PPGs. I have to tell you what our experience is, which is that PPGs are struggling in our locality. We have a forum of PPGs which have six practices, and perhaps ours is the only one that is particularly active. We have great difficulty getting our voice heard when the CQC inspection took place. It's not that we weren't present, but we seem to be relegated to the engagement or the non-professional part of your team. We had conducted a survey which had nearly 10% response rate of all the patients. We found the CQC were asking people waiting in the waiting room for their views and ignored our survey, which had over 700 comments, suggestions, and recommendations. So my question to you and my, in a sense, message is, unless there's a much stronger support for PPGs, for the existence of PPGs, for the role of PPGs, from all parts, from yourselves, from the CCG, and from the NHS generally, saying that you are important, and that I don't know what happens with the other practices when you visit them, but I know that their PPGs are very ineffective. Do you raise that as an issue? And if so, why is nothing happening? Because that's the situation for the last 5 years. So it doesn't seem to be improving in any way. And you say you want us to communicate with you, but how do you communicate? And I particularly had raised the issue of why the inspection doesn't give advice on best practice to our surgery. I was told by the Commission it's not your role to give advice, but it seems to mean a huge lost opportunity that you have this expert team that come around, and you have wonderful opportunity to tell the practice how they could do better, not that whether they just were doing okay in various ticking boxes. I think there's a long way to go to make the PPGs effective, and that will only happen if we get support.
Okay, so firstly, apologies if the inspection didn't look at the survey. Often, we get a lot of information on inspection, so if it was available, we will have looked at it. Any work that the PPG does or doesn't do is fully reflected in our inspection reports, so we will always comment about whether there is a PPG, how it works, how effective it is in working with the practice, and whether the practice actually takes notice of it. So I think going back to what I was saying earlier in terms of the work with Patricia and colleagues, I think given what we've learned over the last 3 years, I think with our new strategy, which is currently out for consultation, so I hope that NAPP take the opportunity to respond to our consultation in terms of our future approach. But one of the opportunities for us is that we will be able to strengthen how we look at PPGs going forward, and to be able to furnish inspectors with more information about what a really good PPG looks like in terms of their practice. In terms of sharing best practice, there is a, it's really having the scars of doing this, but we have a limit as to how far we can go in terms of inspectors advising the practice on how to do things better, because we have had occasions where that has happened. The practice has implemented it, but not necessarily in the way we might have suggested. We have gone back to inspect, and they may still be inadequate or requires improvement, and they say to us, but you told us to do this. So as a regulator, we have to be very careful, but what we do have on our website is we have pulled out from inspections the examples of things that practices are doing really well. So we have what's called the Outstanding Toolkit on our website, where you can find examples, whether it's safe, effective, well-led, of what practices are doing that's really innovative and different, so that people can learn. But again, as I said, in terms of our strategy going forward, I'm a strong advocate for our responsibility as an organisation to share the information in a user-friendly way from 7,500 inspection reports. And that's what we've got to work on, making that simpler to navigate and easier for people to follow.
So I'm afraid I've got hands all around the room, but you'll see from the timetable that we've now run to the end of this session, so we will now move on to refreshments. I think we both, and all of us, want to thank both our speakers who've given us very challenging opening. Thank you both very much.